Hi, this is Dr. Jack West, medical oncologist in Seattle and the president and CEO of GRACE, the global resource for advancing cancer education. I'm happy to be here today with Dr. Minesh Mehta, who is professor of radiation oncology at Northwestern University in Chicago. He also has an exquisite expertise in the management of brain metastases, which is a common complication in many cancers, with lung cancer actually being the leading underlying cause of brain metastases in cancer patients. I'm very happy to have him here today to go over the evidence about the risks and benefits of prophylaxis as well as treatment of brain metastases in cancer patients. Our program today with Dr. Mehta is sponsored by GRACE in partnership with the Longevity Foundation. And with that, I'll turn it over to Dr. Mehta.
Well, Jack, thank you very much. I would like to welcome everybody to this webinar, which is entitled Radiation for Prevention and Treatment of Brain Metastases in Lung Cancer. As Jack mentioned, I'm a radiation oncologist, and I practice here at the Feinberg School of Medicine and the Lurie Cancer Center of the Northwestern University Hospital in Chicago. And it's such a pleasure to have you folks sharing this evening hour with me and with Jack for a topic that is very, very important to patients and families of patients who develop lung cancer. So what I hope to do over the next half an hour or so is to go over the problem, the issues that the problem brings to our attention, how we manage it, what the controversies are, and what we think best practices could be for this significant problem. So let me start by showing you first my conflict of interest disclosure slide. I do have consulting roles as well as roles in several companies, and that's listed here in the conflict of interest disclosure should you need to take a look at that. I'm then going to go on and tell you what the theme of today's discussion is going to be about. I'm really going to focus on 3 points. I'm going to discuss the role of whole brain radiation therapy in preventing the development of metastases in patients with 2 types of lung cancer, small cell lung cancer as well as non-small cell lung cancer. And I will also discuss the role of focal radiotherapy, very highly focused radiotherapy known as radiosurgery, in managing patients who have already developed brain metastases from non-small cell lung cancer. And finally, I will discuss the role of whole brain radiotherapy in patients that have already had surgical resection of, say, for example, 1 or 2 brain metastases, or this focused radiation known as radiosurgery. Should we be following up with whole brain radiotherapy or not? So these are the 3 themes, the 3 objectives that I hope and expect to be able to cover today. So let me start first by talking about this concept of prophylactic cranial irradiation, the use of radiation to prevent the development of brain metastasis. Now, in reality, we're not really preventing the development of brain metastasis. What we are doing is we're using whole brain radiotherapy to treat microscopic disease, small deposits of cells that may already have set up house in the brain that we simply cannot pick up and see with our imaging studies. So we assume that there are no brain metastases because we can't see them, but in reality, small colonies of cells might exist in the brain. And this is a concept that we first came to understand in children with leukemia and subsequently in small cell lung cancer. So small cell lung cancer is a disease that responds dramatically to chemotherapy. But because chemotherapy does not readily penetrate in sufficient amounts into the brain, as a consequence of a barrier known as the blood-brain barrier, this results in the brain turning into a possible sanctuary site where microscopic disease can hang out and hide out without chemotherapy being efficiently able to kill it. As a consequence, even if the rest of the disease in the body appears to disappear, many patients with small cell lung cancer ultimately develop disease in the brain. So failure in the brain remains a common and a substantial issue in many of these patients. Small cell lung cancer is also intrinsically very sensitive to radiotherapy. And as a consequence, relatively low to modest doses of radiation to the brain should be able to wipe out these small clones of tumor cells that hide out in the brain. And as a consequence, we might be able to wipe out this microscopic sanctuary site and prevent the obvious development of brain metastasis. So this concept has been tested in numerous clinical trials, and these clinical trials have in fact validated that we can indeed wipe out the microscopic deposits of cells. In 1999, a meta-analysis was published. What this is a large analysis of all of the randomized trials that were done to address the question about prophylactic cranial radiation in small cell lung cancer. And these trials, this meta-analysis, clearly showed two things. First of all, the risk of developing brain metastasis was clearly reduced in patients who got the whole brain radiation. And secondly, the patients who got the whole brain radiation also had a modest but significant improvement in survival as a consequence of avoiding the development of brain metastasis. So we learned two things. We learned that we could prevent the obvious occurrence of disease in the brain, and we also learned that patients could potentially live longer as a consequence of this. Let me show you this interesting paper. This is a paper that was published in the Journal of Clinical Oncology in 2006. This is a trial where investigators speculated that small cell lung cancer is a very chemosensitive disease. And if it's chemosensitive, it's quite likely that if patients have metastasis to the brain, that this blood-brain barrier might not be as intact as it would be in the normal brain, that perhaps in that setting, chemotherapy might be sufficient to wipe out the disease and get rid of it. So patients with brain metastases received chemotherapy, first-line chemotherapy. So in other words, they were coming in with a new diagnosis of small cell lung cancer and brain metastases, and they were asymptomatic. So they were treated with a regimen of chemotherapy using 3 drugs, Cytoxan or cyclophosphamide, adriamycin or doxorubicin, and a drug called VP16. The systemic response rate, the response rate in the body, the likelihood of the tumor responding to chemotherapy by shrinking 50% or greater was 73%. So almost 3/4 of the patients responded to this chemotherapy. So we know this disease is very sensitive to chemotherapy. But in the brain, the response rate was only 27%. So only 1/4 of the patients responded. So even when obvious disease exists in the brain and the blood-brain barrier might be partially disrupted, it's not sufficiently disrupted to allow enough chemotherapy to get in to produce the high 70, 75% response rates that we would like to see. And that's why radiotherapy makes sense in this disease. The meta-analysis that I talked to you about, the one that was published in 1999, was a very elegant study that was done. In this study, they looked at 7 randomized trials with almost 1,000 patients. And these patients had all undergone chemotherapy previously, with or without radiation to the chest, and all of them had obtained what we would call a complete response. In other words, all known visible disease had disappeared. So effectively, we would have said these patients have no more disease. However, we did suspect that disease would be hiding out in the brain. And so that's why these patients were randomly assigned to receive whole brain radiation or not. What I show you on this slide, which shows both the risk of death and the risk of developing brain metastasis, is a reduction, a shift from the central bar, which is labeled at the point marked 1.0. If everything lined up at 1.0, it would imply that the experimental treatment is no different than the standard of care, which is no treatment at this point in time. Any shift to the left implies a reduction in the risk of death and a reduction in the risk of developing brain metastasis. And any shift to the right would imply worsening of the results. So we see here categorically that both for the risk of death and the risk for developing brain metastasis, there is a reduction across the board. In fact, the risk reduction for brain metastasis is 54%, which is quite substantial. The benefit in terms of reducing death is positive and substantial, but not as large as the reduction in the risk of developing brain metastasis, but still a positive effect. Given that these patients started off mostly with what we would call limited stage lung cancer, in other words, the disease was limited to the chest, we had excluded the significant majority of patients that developed disease outside the chest. We call these patients extensive stage small cell lung cancer. And in 2007, a trial was published that was done primarily in Europe. And in this trial, they took patients with extensive stage small cell lung cancer. On this slide, I show you the design of the study. Patients received chemotherapy, and if they responded, if they had any response whatsoever, in other words, the restriction was quite a bit lax here. They did not have to achieve a complete response. They just needed to have some response. If they got into a response, they either received prophylactic radiation to the brain or not. And the idea here was to look for a risk reduction in terms of the development of brain metastasis. As you can see from this graph, the line in white represents the patients who did not get radiation to the brain. So this is sort of the natural history in terms of the risk of developing brain metastasis. Over a period of time, on the x-axis, the time is shown in 4-month increments from 4 to 8 to 12 months and so on. The white line keeps on going up till about 16 to 20 months when almost 45 to 50% of the patients end up developing metastasis to the brain. The line in yellow represents the patients who received whole brain radiotherapy. And that line is consistently below the white line, implying a reduction in the risk of developing brain metastasis. And this reduction is quite significant. We express this in terms of a ratio that we call a hazard ratio, and the hazard ratio of 0.27 is a very dramatic reduction in the risk of developing brain metastasis. Now, this trial, like most trials, had some flaws in its design, but in spite of that, it clearly showed a reduction in the risk of developing brain metastasis. What was more interesting about this particular trial was a secondary publication that came out of it in the Journal of Clinical Oncology in 2009, and I'm showing you this very, very busy slide. And on this busy slide, there are again 2 lines for every graph. There is a yellow or a gold line and a blue line, the dotted line. The gold line represents patients that received radiation to the brain, and the blue line represents patients who did not. And here, what they were looking at was a change in patient-reported quality of life parameters. So, for example, let's look at the panel marked B. This is a panel where they looked at hair loss. Clearly, the line in yellow sits on top of the line marked blue. In other words, patients who got the radiation were more likely to lose hair than the ones who did not. That's intuitively obvious. You would expect that. But what I would like to point your attention to is the graph marked E. This is a graph that is looking at something called cognitive functioning. How well do patients think? Now, the reason I'm showing you this slide is we know that whole brain radiotherapy decreases the risk of developing metastasis in the brain. But the concern is the possibility of side effects from radiation to the brain. Can radiation cause decline in memory functions, in functions of the brain? And one way to measure that is to look at cognitive function. And if you look at these bars, there is indeed a small difference. The orange or yellow gold line is slightly lower, especially for the first 4 to 6 to 8 months compared to the blue line. So there seems to be a small early initial decline, but then it catches up. It seems to parallel the functioning of the patients that did not get the whole brain radiation. So yes, there probably is some reduction in cognitive functioning. It's not very large, and it's not sustained over time. It seems to occur in an early phase, and then both groups of patients appear to be doing about the same. And I will keep on coming back to this point a couple of times in my next few slides. Let's summarize so far what we've talked about in terms of the role of prophylactic radiation in extensive stage small cell lung cancer. This radiation reduces the risk of developing brain metastasis in patients with extensive stage disease, but there is no difference in time to progression of the disease outside the brain. I did not show you the data for that. It also prolongs the period of time that patients remain free of failure. We call that failure-free survival. And it actually also prolonged overall survival. So even this group of patients benefited in terms of survival prolongation. So it's reasonable to conclude that in both cohorts of patients, extensive stage as well as limited stage, if a patient responds to the initial therapy, there is possibly a role for prophylactic cranial radiation for these patients. Now, if this works for small cell lung cancer, could it work for other diseases? And in fact, this interest was stimulated in recognition of the fact that as patients with non-small cell lung cancer have started to live longer, their risk of developing metastasis in the brain has also increased over time. To try and address this issue, a clinical trial cooperative group known as the Radiation Therapy Oncology Group, or RTOG, launched a prospective randomized trial which was comparing prophylactic cranial radiation versus no radiation to the brain in patients with advanced non-small cell lung cancer. This trial was originally designed to randomize these patients to 30-gray radiation, which essentially takes 15 days to deliver, or observation. And the schema is illustrated on the slide that I have up right now. The study ran from 2001 to 2007. The targeted accrual, the study was designed to answer the question if about 1,100 patients, just a little more than 1,000 patients, would have been entered on the trial. Unfortunately, in this almost 6-year time period, the accrual was only a third of what was expected. Only 356 patients were accrued. So the trial ran very, very slow. And of these 356, only 340 patients had enough data and had met the requirements to be considered evaluable for analysis for this particular trial. So unfortunately, we never completed the trial. And as a consequence, not surprisingly, we find in this graph that's looking at overall survival that there is no difference in overall survival. The red and the blue curve superimposed directly on top of each other. So survival was unchanged with additional prophylactic cranial radiation. Well, how about the parameter of disease-free survival? The prophylactic cranial radiation arm, illustrated in red, is consistently above the blue line. So these patients did better in terms of failure-free survival. And the reason they did better was because they developed less brain metastases, as shown on this particular slide. The line in blue are the control patients who did not receive whole brain radiation, compared to the line in red, which is the group of patients that got whole brain radiation, and they have a lower risk of developing brain metastasis. So clearly, the risk of developing brain metastasis was reduced and was statistically significant, even though the trial did not reach the accrual that was necessary to establish this. What was very interesting about this trial was that they also tested brain functioning through a simple test called the mini-mental status examination. This is somewhat of a crude test. This test detects big changes. If patients have significant changes in the brain, this would be picked up with the mini-mental status examination. And what we see here, let's just focus on the green and the red lines that you see at the bottom. The green and the red lines at the bottom represent what we call the change in score over time. So what we can clearly see is that the green line is consistently on top of the red line. The green line represents patients who did not get prophylactic cranial radiation. The red line represents patients who received prophylactic cranial radiation. There is very little separation between these lines. If we look at the actual score, which is shown on top with the red and the blue line, there is very little separation. So this crude test, a test that looks for very obvious changes in brain functioning, showed no difference. So that's good news. However, when we look at a more sophisticated test, as shown in this slide, this is a test known as the Hopkins Verbal Learning Test, which looks for the ability to retain words and then reproduce those words at a later point in time. We see that the line in red at the bottom is consistently below the line in green, implying that patients do in fact have a reduction in their ability to memorize and reproduce words as early as 3 months, but then it starts catching up. And in fact, you can see that in the upper two lines. The blue line represents patients who did not get prophylactic radiation. The red line represents patients who did. And you see a dip at 3 months, which tends to come back a little bit. Remember, we saw the same thing in the cognitive decline slide for the small cell lung cancer patients. There seems to be a small dip, and it seems to recover somewhat over time. So it's not a huge dip. It's not a huge loss in terms of ability to recall words, and it does seem to bounce back at least a little bit with time. Now let's put this RTOG trial in context with the other trials that have looked at the same question. And on this slide, I have listed a total of 5 different clinical series, randomized trials, and then I've summed them up at the bottom in the row that's marked cumulative experience. So this now includes over 1,000 patients. And if you look at the first 2 columns, whether they received the prophylactic radiation to the brain or not, there is indeed a significant reduction from about 13 to 27% without the radiation down to single digits 4 to 9% with the radiation. So we clearly have every trial done in this disease showing a benefit in terms of the reduction in the rate of developing brain metastases. But obviously, this appears to come at a price. There is some decline that can be measured using sophisticated tests such as the Hopkins Verbal Learning Test. So we have to ask ourselves, where is the balance? We know that neurocognitive decline occurs in patients that get radiation, and it may occur relatively early, as early as 3 or 4 months. In a separate study that we did at my institution, we looked at the time course of neurocognitive decline in 200 plus patients who had received whole brain radiotherapy. And we made 2 observations. We found that the time to decline was longer. In other words, patients remained free of declining in their cognitive function if their disease responded. So if you control the disease, their cognitive function was maintained better, which would imply that the disease itself also contributes to a decline in cognitive function. The second thing that we learned was that of the many different cognitive functions we can test, the one that was most susceptible to early decline, the one that would go down earliest, was in fact memory, something that the Hopkins Verbal Learning Test actually measures. This becomes intriguing because it brings in the potential for doing trials that would try and spare memory, and we'll talk about that in a little bit. So let's look at this group of patients with non-small cell lung cancer and try and make some sense out of this. We have about 300 plus patients who got either whole brain radiation or not, with a clear decline in the occurrence of brain metastases, which comes at a price, a slight early reduction in memory, some of which bounces back with time. Obviously, this would be a good thing in patients that were at very high risk of developing brain metastases. And patients that have adenocarcinoma or large cell carcinoma, something we call non-squamous non-small cell lung cancer, have more than a quarter risk, more than 27% risk of developing brain metastases. And these patients might potentially be better served by looking at the possibility of prophylactic cranial radiation. But what about the neurologic decline, the cognitive decline? Can we do something about it? Well, there are many options. One option is to give drugs that spare cognitive function. One such drug is a drug that came out from the Alzheimer's work. It's a drug known as Memantine. The RTOG has just completed a very large trial of upwards of 600 patients, a trial known as RTOG 0614, where half the patients received Memantine with whole brain radiation and half the patients did not, the goal being to identify if Memantine actually protects memory. We don't have the results of this trial yet. It's expected that before the year is out, we will have the results. So we're quite excited to find out if this drug actually helps reduce the likelihood of developing cognitive decline when whole brain radiation is given. As you can imagine, if it does that, it would be a game-changing event, and this would be something that would become very common practice. The other option is to look at technology to try and identify regions of the brain that we think are most likely to be causative for this memory decline. And one of the theories that is out there is the stem cell theory that suggests that there are neuroprogenitor stem cells in the brain that live in and around an area of the brain known as the hippocampus. And that these cells replicate and reproduce consistently and produce neurons that help us develop new memories. But that these stem cells are quite sensitive to radiation, and when patients get whole brain radiation, these stem cells are depleted, and that might be part of the reason why memory deficits occur. So perhaps if we could spare these stem cells that live in and around the hippocampus, then we might be able to reduce the occurrence of memory decline. To test that, the RTOG just last week launched a clinical trial of hippocampal avoidance or hippocampal sparing in patients receiving whole brain radiotherapy, and it'll be interesting to see what the results from that trial are. The trial has just opened, so it'll probably be a year or so before accrual is completed on that trial. I'm now going to shift gears and talk to you not about prevention, but actual treatment of metastases in the brain. This is something we refer to as definitive whole brain radiotherapy. So whole brain radiotherapy used to try and treat the metastases in the brain. The RTOG, again, has done many, many clinical trials enrolling thousands of patients, and we can go back and look at these patients who got whole brain radiotherapy. And what we find is that patients with brain metastases don't do very well. Many of these patients have relatively short survival. As you can see from this table, the survival can range from anywhere as little as 2.3 months to 7.1 or longer. But it's short survival. It's measured in months. But even within this group of patients with brain metastases, there are different tiers or different categories. Some, labeled as class 3 patients in this table, have very poor survival, only a couple of months. The other group, class 1, relatively speaking, has better survival compared to class 3. So we know that these patients are different, that whole brain radiotherapy produces perhaps different effects in different groups of patients with brain metastases. To try and further answer that question, Dr. Sperduto, who works out of Minneapolis, has gathered a large database of brain metastasis patients from 10 institutions and has been publishing a number of clinical papers on this particular data set. Let me show you 2 slides to illustrate to you how these data can be useful in determining the role of whole brain radiotherapy. One of the first questions that Dr. Sperduto and his colleagues asked was whether the type of cancer actually makes a difference. And in this slide, you can see that in this database, there were over 4,000 patients, almost 2,000, 1,800 or so had non-small cell lung cancer, about 600 plus had breast cancer, and almost 500, just under 500 patients had melanoma. And when we look at these patients by different histologies, different types of tumors, we find that their survival is different. In this table on this slide, if you focus your attention on the first 2 tables, you see that by tumor type, the survival is different. So, for example, breast cancer patients appear to live longer when they develop brain metastases compared to patients with melanoma or non-small cell lung cancer. So, indeed, the type of cancer may make a difference in terms of the outcome of patients who are treated with whole brain radiotherapy. More importantly, what we have recently observed is that if we treat patients with brain metastases with whole brain radiation, and we come back and look at their brain with an MRI scan, we identify that a reduction in the size of the brain metastasis, regression of the brain metastasis, in fact is suggestive of improved survival as well as improved cognitive function. And this latter aspect is quite intriguing. So let me just show you the data from this analysis. This was a cohort of 135 patients who were still alive at 2 months after radiation therapy, who were divided into so-called good responders or poor responders based on the amount of reduction in the disease in the brain at the 2-month measurement point in time. What we see here is the green line versus the blue line. The good responders actually live longer than the poor responders. So even controlling the disease in the brain appears to have an influence on the overall survival of patients, which implies that we should really maximize our efforts to control the disease in the brain and not minimize those efforts. Now, obviously, we would want to minimize the efforts if the effort was deleterious. So if whole brain radiotherapy was producing terrible side effects, we would want to hold off on doing that. But as you can see on this graph, which is a graph of neurocognitive function, this is a graph that actually measures motor skills, how fast somebody can operate something. We find that the green line is better than the blue line. The green line are the good responder patients. The blue line are the poor responder patients. Remember, both groups of patients got whole brain radiotherapy. And obviously the ones whose disease is controlled do better. So controlling the disease is important in predicting who's going to live longer and who's also going to be better in terms of cognitive function. So this is an important point to bear in mind. I'm now going to shift to a different type of radiotherapy, a technology known as radiosurgery, which is highly focal treatment of only the visible metastasis, not the whole brain. We're not chasing microscopic disease in the brain, but essentially spot treating one or more lesions. This concept was tested again in a clinical trial by the RTOG in a paper that was published in a journal known as The Lancet in 2004. This is the survival of patients with a single brain metastasis. The blue line represents patients who got whole brain radiotherapy and radiosurgery. The yellow line represents patients who got whole brain radiotherapy alone. Clearly, the addition of radiosurgery prolongs survival in patients with a single brain metastasis. The majority of these patients had non-small cell lung cancer. it's reasonable to conclude that in a patient with a single brain metastasis, the addition of radiosurgery to whole brain radiotherapy improves survival and should be strongly considered. In patients with more than one brain metastasis, if we look at all comers, there are 3 different trials we're looking at here. All of these trials had a design where patients received either whole brain radiation or whole brain radiation plus the technique of stereotactic radiosurgery. The third box, colored black, shows the local control rate of the brain metastasis in patients that got both treatments, whole brain radiation and stereotactic radiosurgery. And the box to its left shows patients who received only whole brain radiotherapy but no radiosurgery. Consistently, the numbers in the black box are superior to the numbers in the blue box over to the left, implying that even in patients with multiple brain metastases, the addition of radiosurgery improves local control, but there is no evidence of improvement in survival in these patients. So yes, we can improve local control by adding radiosurgery, but not impact survival in patients with more than one brain metastasis. Now, the studies I showed you typically included patients with 1, 2, 3, or 4 brain metastases. But there are people who have published their experience with patients with more than 4 brain metastases. This is a paper that was published in a journal, the International Journal of Radiation Oncology, in 2006. And in this particular paper, they treated 205 patients with various malignancies who received radiosurgery for their disease. And the authors went on to conclude that patients did quite well. The problem, of course, here is we don't have a group to compare with. All of these patients were treated, and they were selected to be treated with this particular modality. So we don't really know whether any improvement or so-called improvement that we might see is genuinely because of the treatment or as a consequence of only selected patients having been chosen for this particular treatment. So now let's look at the impact of whole brain radiotherapy in patients that get such local therapy, such as radiosurgery or surgery, because there is an increasing practice of withholding whole brain radiotherapy in these patients. They get surgery or radiosurgery, and whole brain radiotherapy is withheld. So let's look at the impact of that. What happens? In this table, I'm showing you results from a surgical trial. In this surgical trial, patients with a single brain metastasis were resected and afterwards either received whole brain radiotherapy or not. And if we look at the first 3 columns in this slide, on the left you can see that we are looking at 2 groups of patients who had failure anywhere in the brain, or in the second row, patients that had failure only at the original site where the tumor had been removed. The second column represents the 46 patients who did not get radiation to the brain. The third column represents the 49 patients who did receive radiation to the brain. The rate of failing in the brain in the absence of whole brain radiotherapy is 70% without whole brain radiotherapy. And this is reduced 3-fold down to 18% with the addition of whole brain radiotherapy. The risk of failing at the original site where the tumor is removed from approaches 50% without whole brain radiotherapy and drops down to 10% with the addition of whole brain radiotherapy. So clearly whole brain radiotherapy after resection is beneficial. This is a busy slide, a busy table, where I have taken now 5 different cohorts of patients. They're similar in the sense that these are all randomized trials where patients either had resection of their brain metastasis or radiosurgery. And half of them did not get whole brain radiotherapy, half of them did. Let's just go down to the very bottom row, which is the range that we can see here. So if we take all of these patients and add them up, what do we see? Let's first look at failure anywhere in the brain in the absence of whole brain radiotherapy. So go over to your right and look at the third column that is entitled No WBRT and go down to the bottom number in the row that's marked range. You can see that the likelihood of a patient developing disease in the brain, if they do not get whole brain radiotherapy, approaches 80%. It's 70 to 80%. If they get whole brain radiotherapy, now I would like you to go over to the sixth row that is marked WBRT, and that says any brain failure, go down to the bottom, that risk is effectively halved or reduced down to 1/4. It goes down to 24 to 47% with the addition of whole brain radiotherapy. So clearly the use of radiosurgery alone or surgery alone is associated with a very high risk of failing in the brain, 70 to 80%. And this can be substantially reduced down to 24 to 47% with the addition of whole brain radiotherapy. Now, we talked about the impact of whole brain radiotherapy on the mini-mental status examination in the prophylactic cranial radiation group when we talked about the non-small cell trial. What about patients that actually have brain metastases? Do they do worse in terms of their brain functioning if we add the whole brain radiation? So these are results from a Japanese trial. They looked at 82 patients on whom they had measured the mini-mental status exam score, and they looked at two parameters. They looked at how long it took for patients to drop 3 points on their score. A 3-point drop is considered significant. If you drop 3 points, that's quite a bit of loss of memory function. The patients who did not get whole brain radiotherapy on average dropped 3 points in less than 8 months. In 7.6 months, they dropped 3 points. Remember, they had not received whole brain radiation. And yet half of them dropped 3 points in less than 8 months. We expect that whole brain radiotherapy patients might do worse because of the effect of radiation on the brain. But surprisingly, in this study, the patients that got whole brain radiotherapy took longer. They took over 16 months to drop their score by 3 points or more. And we see the same trend when we look at what we call landmark analysis at different time points, at 12 months or 24 months. We find that the patients who got the whole brain radiotherapy were less likely to have cognitive or neurologic deficits in their brain compared to patients who did not get whole brain radiation. So what's going on here? There can only be one logical conclusion. And the logical conclusion is that yes, indeed, whole brain radiotherapy can cause a decline in cognitive function. But recurrence of disease in the brain is a far more efficient way of causing decline in memory function than whole brain radiotherapy. In other words, progressive disease in the brain is worse than whole brain radiotherapy alone. One other study bears consideration. This is a small study that came out of MD Anderson Hospital, and in this study, they looked at this fancier test, the HVLT, the Hopkins Verbal Learning Test, that I had mentioned to you earlier as well. And here they looked at a group of patients that had received radiosurgery only or radiosurgery plus whole brain radiotherapy. And if we look at the 4-month time point, at 4 months, the likelihood of decline in this memory function is greater for the patients who received whole brain radiotherapy, 49%, compared to 23% for patients who did not get the whole brain radiotherapy. But these data are very consistent with the other graphs where I showed you that cognitive decline can occur early at 3 or 4 months, but then bounces back. So in part, this is a reflection of when you choose to measure it. So if you choose to measure it at a point when it's most likely to be down, yes, you do see it. But if you were to come back a few months later, this difference would probably have become much more narrow, might not even be statistically significant. So this is a good point for me to conclude. Let's summarize what we have discussed so far. We've talked about the roles of whole brain radiotherapy in patients with brain metastases, both in small cell lung cancer and in non-small cell lung cancer. We've talked about a preventive role in patients with small cell lung cancer, which is well established. It reduces the likelihood of developing disease in the brain and prolongs survival, both for patients with limited stage and extensive stage disease. In non-small cell lung cancer, we have almost 1,000+ patients that have now been randomized to preventive or prophylactic trials, and they consistently show a reduction in the risk of developing brain metastases, but do not categorically show a survival improvement. And in the RTOG study, although the mini-mental status examination was not changed between the two arms, the Hopkins Verbal Learning Test, which measures the ability to memorize and retain words, did show an early decline with whole brain radiotherapy, with some regain of function over time. We've talked about the therapeutic use of whole brain radiotherapy, which is used primarily for patients with multiple brain metastases and results in regression of disease. And we have learned that regression of disease is a good thing because it is associated with longer survival and better preservation of cognitive function. We discussed what we call the adjunctive role or the additional role of whole brain radiotherapy after either surgery or stereotactic radiosurgery. And we saw that the addition of whole brain radiotherapy reduces both local failure in the tumor bed or the targeted area and also reduces the likelihood of developing metastasis in the rest of the brain. In fact, if we look at the data collectively, the likelihood of developing more metastases in the brain approaches 80% if whole brain radiotherapy is withheld. And this can be reduced down by half or a fourth with the addition of whole brain radiotherapy. Finally, we must also address toxicities. We've talked about memory changes, and we've talked about the fact that when we use a tool such as the mini-mental status exam, which looks for significant large changes, we find only minor changes. These seem to occur early, and in fact it appears that it's worse if the tumor progresses, and the tumor effect may be more nefarious than the effect of the whole brain radiotherapy. When we use finer tools, like the Hopkins Verbal Learning Test, we pick up some early decline in memory changes, especially around the 3-4 month time period, but with some rebound thereafter. We've seen that in small cell lung cancer patients, in the European trial, the Slotman trial. We've seen that in the non-small cell lung cancer preventive trial that Dr. Movsas had presented. And we have seen that also in patients that have been treated for brain metastasis. So this is now a consistent finding in many trials, suggesting the potential for preventing dysfunction, either with the use of drugs such as memantine, for which a clinical trial has been completed, or with technological innovations that spare the areas where these stem cells live, such as in and around the hippocampus. And those trials are ongoing. So I would like to thank you for your attention.